Good evening, delegates and faculties member. Thank you for joining Shield Correct. And today we are back with our hit series Icons in Conversation with Dr. Ritu. And today we have a special guest from Cairo, Dr. Munir Mustafa. So, and the topic for today's session is CS Niche, a view from within. So, let me introduce our sponsor for this program, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIOG, AMRCOG. Ma'am is obstetrician and gynecologist in IVF and founder and CEO of 360 Degrees Healthcare Studio in Pune. And ma'am is also a consultant in Inamdar Multi-Speciality Hospital, Pune. And ma'am is infertility test tube baby specialist. Ma'am has done NUHS from Singapore. Ma'am is co-founder of MAAM board and board member of SWWC. And now let me introduce our speaker for the day, Dr. Munir Mustafa. Sir is obstetric and gynecology specialist in Cairo Baby Center from Cairo. Sir is also RCOG Associate, DOWH from Ireland. Sir has done CICE Diploma, F from France, hysteroscopy trainer in ASFMS in various countries, Iraq, Sudan, Libya, Bangladesh, UAE. Sir is co-founder and editor of Libyan Journal of Medicine and senior member of Egyptian Inventors Syndicate, inventor of Pompino, pioneer endoscopy from Egypt and inventor of MIS heteroscope in Tontara, Germany. So I welcome Dr. Ritu and Dr. Munir Mustafa for today's webinar. And I hand over the session to Dr. Ritu ma'am. Thank you.
Yeah, thank you, Nishan, and thank you, Shield Connect, for providing us the platform for this knowledge sharing program. Friends, today I am in a very bad throat. So today we are having a very renowned speaker with us, Dr. Munir Mustafa. A very warm welcome to you, Dr. Mustafa. And I can say salam to all of my friends who have joined all across the geography. As all of us know that knowledge is not limited to any country or any boundary, and knowledge always increases by sharing. With this motto, I initiated this series, The Icons in Conversation with Dr. Ritu. Every week, every Thursday at 8:30 p.m. Indian Standard Time, we are coming with one speaker on the different topics to discuss in deep. So today's topic is very, very important, the cesarean section niche. So I think in the mind of the every gynec, every obstetrician, this is in the mind that how they will further proceed in the patients of the cesarean section niche. So without wasting much time, I'm handing over the session to my friend, Dr. Mustafa, to deal within this with the great detail. And later on, whatever the questions you are having, you can put on the chat box. So Nishan can take that later on. Besides that, some friends have joined today. Firstly in this my session, so very, very warm welcome to all of you. And the program is going live on the YouTube. I have already posted the YouTube link. Those who are missing the program can see later on the recordings on the YouTube also. So a very warm welcome, Dr. Munir Mustafa. I am handing over the session to you. Yeah.
Good evening, everyone. Many thanks, Dr. Ritu, for this event, for creating this event and allowing us to have some scientific discussions. Thank you for the kind invitation and a nice introduction. Today, I'll talk about a very trending topic in the gynecology these days, which is the cesarean scar niche. Because of the cesarean section rate all around the world is increasing. In Egypt, we have one of the highest rates in the world of cesarean section. So we have very raw area to study the complications, including the cesarean section niche, abnormal placenta, placenta accreta, placenta previa, and this stuff. For me, as a hysteroscopist, I studied the niche not because I was interested in it before. Now I'm interested in it, but I studied this issue because I had a problem. Every time the patient comes with a report of ultrasound with a documented niche in the ultrasound, then the patient, by questioning her, she has the symptoms of the niche, which is abnormal uterine bleeding, post-menstrual spotting, and pain. We'll discuss this later. Then we do the hysteroscopic operation. The patient 2-3 months becomes very well, but when she goes for another ultrasound, the report still says she has a niche. So I started to look, where is the problem? Is it from the ultrasound? Is it from the technique? Is it from the definition of the literature? Then I had to study very well the pathology. In general, the old or the standard technique for any scar problem, it is excision and resuturing. We remove the scar itself, whether by abdomen, laparotomy, laparoscopy, or transvaginal. We remove the scar and we suture all the area. But with the hysteroscope, we don't remove and we don't suture. So we have to have a good understanding of what's going inside this pathology, because we are not going to suture or remove it. So I started looking about what is written in literature about the niche, and I had some issues about how did the hysteroscope helped us to understand and to have a new view regarding this pathology, apart from what is there in the literature. First thing was the definition. We use, among literature, we use the term Caesarean scar niche, defect, ismocele, diverticulum, pouch. All the terms are used in the same way. And the definition is the presence of a hypoechoic area within the myometrium of the lower uterine segment, reflecting discontinuation of the myometrium. It is a scar with a malhealing or a defective healing inside the mucosal surface of the uterus. But this definition, they don't match the clinical finding. If there is a problem in the healing, this doesn't cause the symptoms directly, nor guide through the management. So I have to see how did the terminology was used. For example, the word defect, it means a fault or something on a way it has been made. That means it is not perfect. A defect is something I have to see. You can see it by the ultrasound. But the niche is a hollow place to contain statiu. This is the dictionary definition. But in the language, niche means the ability to retain. It's like a shelf. It's something that can retain another object inside it. For example, if you are sitting in the room now and there is a defect in the ceiling of the room, this is defect, but it can't be a niche because it doesn't hold anything inside. So what I think is that what you see by the ultrasound is the defect, not the niche. You need another criteria plus the presence of the defect to say there is a niche. That's why the patient, after the hysteroscopic repair, she still has a niche, but she still has a defect, but she doesn't have a niche. That's why we get the conflict. Just some numbers for the revision. In literature, there are a very wide range of number of rates of the cesarean section niche, but it's from 18 to 80%. But I think it's around 50% of patients who have cesarean section have a cesarean scar niche. Of course, after previous 3, it reaches up to 90%. It's probably a secondary cause of secondary infertility. This is one of the most common complaints we see, because I work in the back of the IVF centers. Recurrence rate after laparoscopic suturing has not been studied, but up to 40% in patients who have undergone suturing by laparotomy reported the symptoms of the niche again. Okay, I'm not here discussing the etiologies, but there are many etiologies, theories for the etiologies. We have lower cesarean section, low incision, cervical incision, the wound characters, tension of the wound, malapposition of suturing, endometrial involvement or decidual involvement during the suturing, suturing materials, layers, locked sutures, adhesions, non-closure of peritoneum, inadequate hemostasis, post-operative infection, or patient-specific factors. it still occurs anyway, and the big answer to the etiology is no one knows why. I think the clinical definition of the niche, now I'll start to show up my view regarding the niche. It's a multi-aspect pathology caused by malhealing of the cesarean section wound, leading to anatomical disruption and local reactions presenting with a spectrum of symptoms. Understanding the pathology and consequence is the core of appropriate management. So here we have to study the anatomy of the cesarean scar niche. This is the anterior uterine wall. You see it on the left side. On the right side, you see the posterior uterine wall. This is the defect. This is what we see by the ultrasound, and this is what people call the niche. Then you have here the residual myometrium. This has an obstetric importance, not gynecological now importance. This is the niche. The niche is the area at the lower segment, at the lower edge of the defect that makes the defect retain the fluid. Then we have the healing surface of the wound. This wound, this healing surface, there's an active process occurring there. Now, with this view, we can't call the whole pathology niche, because niche is a part of the pathology. I think the right name should be Caesarean scar complex, especially if you know that Morris, who discovered the niche in 1995, he called the spectrum of symptoms of this pathology Caesarean scar syndrome. So I think the good name will be Caesarean scar complex, and it has many pathologies inside. First thing, it's the scar thickness, residual myometrium. The residual myometrium has a risk of uterine wound dehiscence or rupture in the subsequent pregnancies. There are many cutoff points of thickness in literature, starting from 3 millimeter, 3.5, 4 millimeter. That below this, the wound should be resutured because it is a cause of uterine wound dehiscence. The second pathology is the niche. We'll discuss every one now. The second one is the niche. The third one is the chronic inflammation. The fourth one is the malhealing process. The fifth one is the endometriosis, and then the uterine malcontractions. So the scar thickness, this is number one on the pathology complex. It is the residual myometrium. This is the name. This is seen and measured by the ultrasound. It has the risk of wound dehiscence or rupture uterus. As I told you, there are many numbers. I use the least one in literature, which is 3 millimeter or 1/3 of the total thickness. Today, I see a lot of cesarean sections, cesarean wounds inside the cervix, cervical scar. So I think when the cervical scar is lower, when the cesarean scar is lower, and even in the cervix, it's safer when you have a lower residual myometrium, because these patients usually they don't go into labor in the next pregnancy. You have elective cesarean section, and there won't be any risk for uterine rupture. But this is not in literature. This is just my opinion, because in Egypt we have a very high rate. I see the cesarean scar in the cervix, because it's probably during the first or late first or second stage of labor they do this. Second pathology, it is the niche, the shelf. This piece which acts as the shelf, it collects the menstrual blood in the defect, and it makes post-menstrual spotting. During menses, it collects some blood, and after the menses, the blood starts to spot. This is pathognomonic of Caesarean scar. I diagnose it on the phone when the patient is previous and she has post-menstrual spotting. 99% she has a niche. It also affects, if the patient will require pregnancy again, it affects the IUI, intrauterine insemination, embryo transfer, and even IUD insertions. Many times I see gynecologists trying to insert the IUD, and they just go inside the defect when they hit the niche. It also may retain an embryo, because it retains the menstrual blood. Sometimes it retains a falling embryo, and you have an ectopic ectopic scar niche pregnancy. This is different than the scar pregnancy, which is not ectopic. We have two types here, just to say. We have endophytic scar pregnancy, which is inside the uterus but attached to the scar. This probably could lead to placenta previa, placenta accreta. And we have the endophytic, exophytic ectopic pregnancy. This is inside the defect. The embryo is inside the defect and attached to the scar. This is due to the niche, but the scar pregnancy is not due to the niche. This is due to the scar. So here we have to say that niche is defect with symptoms. Many patients have defect without symptoms, and this is not a niche. That's the most important point I'm trying to say in this part of the presentation. That many patients, they are previous cesarean section. When they do ultrasound, they have a defect. It is just like any defect in any scar in the body. It is like the defect they have in their abdomen. And if they don't have symptoms, this is not a niche. There is no fluid retention pathology. Some patients have symptoms, but they don't have a defect. This is not a niche, but still it's part of the cesarean scar complex, as we'll see later. So a niche should not be diagnosed by ultrasound. By ultrasound, you diagnose the defect, and we collect the data clinically using with symptoms, and then we have the diagnosis of niche. That's why when I correct the niche by hysteroscope, the patient, when she goes for ultrasound, should report a defect, not a niche. Both the terms should not be used in the same way. This is how we see the niche in the hysteroscope. In the hysteroscope, the point is I see a hidden area in the scar where the scar. See, it's hidden. You see the bubbles? They are hiding from me. This is the defect hidden by the niche. When you remove the niche, the defect is no more hidden. You see, I call this the shy bubble sign. When you have a bubble, part of it only appears and the other part is inside. That means you have hidden area inside the defect. Another thing characteristic is a very thick mucus plug with brown or dark color. It's resistance even to the fluid of the hysteroscope because it's attached away from the pathway of the fluid of the hysteroscope. It's attached inside the defect. This is accumulation of menstrual blood and inflammation throughout time. In the same way, when you see inside, you will see the hidden part. You see this plug? It's big. It's very viscous. It comes as one part inside. After the operation, you'll find it outside as one part. Very characteristic also. You see here, when you go back to see, you have hidden area. This is the area hidden. This is the scar, the white tissue, the scar, and we have hidden area upward. The third pathology is the chronic inflammation. This is due to the discharge. Some niche, they just collect the menstrual blood and they get it flushed a few days after the menstruation, and then during the same cycle we don't have any problems. Bigger niches, they retain the fluid and the menstrual blood for longer time, for more than weeks. So they give time for inflammation and infection. Then the patient will have chronic discharge, chronic pelvic pain, dyspareunia, inflammatory polyps from within the site of the niche, adhesions, infections that can even go into the cavity and cause endometriosis. The state of inflammation here is eroding the tissue around it, and it can be progressive, and it also affects the lateral and posterior wall. That's why we'll see now how we treat it. We'll see in some patients, we will find the inflammation and the defect all around the cervix, not just all around the scar, not just anterior. Okay. Fourth thing is the healing process. Now the area of the raw area inside the scar, sometimes there are an ongoing healing process. There are new vessels of blood coming, for the healing, and they don't find tissue. So you just, with the hysteroscope, you see flying free vessels, and this is a cause of abnormal uterine bleeding, not related to the niche. This video is even important. See, the patient doesn't have a real niche. This is defect. This is a very big defect, but there is no there is no niche, there is no shelf, there is no fluid collected, there is no inflammation. Okay, the patients complain blood. The polyp here is just a transit pathology, but the main pathology, it is these blood vessels coming to heal the scar, and they don't find tissue, and so what happens that they bleed throughout the cycle. Abnormal uterine bleeding due to free blood vessels or any genetic at the healing surface without the presence of a niche. Okay. Also, the chronic presence of endometrial tissue inside the defect can cause endometriosis, adenomyosis, cystic adenomyosis. We see this frequently when we start resecting the niche. This is a cause of dysmenorrhea. Okay, like this. It's a mixture of infection, inflammation, and cystic adenomyosis. You see small collections of chocolate-like material like this one. The complaints of this patient is not related to the niche itself. It's now related to these cystic collections which every month reform. Okay, I hope the view is good with you. This is one. This is another example. You see from up. This is from inside the scar itself. Here I'm afraid, because this is the scar itself. We should not work in the scar. We work around the scar. The scar is very dangerous to work with. You can make perforation very easy. But this is a collection. This is cystic collection of chocolate inflamed material, and the patient symptoms will not finish if you left it like this. You have to evacuate it and open and remove the space, the collecting space. You see this? Okay. Now, to the last pathology and the least found in literature, it is the contractile activity of the non-pregnant uterus. There is something called the contractility cycle of the uterus. The uterus contracts from the fundus to the cervix in the follicular phase and stops during ovulation. Then this contraction starts from the cervix to the fundus during the luteal phase. The scar myometrial discontinuity due to the scar itself can cause contractions around the scar and constriction, something like constriction ring and uterine malcontractility. This could lead to the inadequate uterine contractility and accumulation of the fluid from the niche inside the uterine cavity. There is little literature about this, but we see a lot of patients whom you find a sort of hematometra inside the uterus with a large uterine niche, and they don't get the blood out easily. They sometimes need the cervical dilatation, and this is a common cause of chronic endometritis associated with the niche. These patients cannot undergo any trial of artificial reproductive ART, assisted reproductive techniques without repairing this niche, because every cycle they have chronic endometritis increasing. So what I'm saying is that what we call Caesarean scar complex, because we have a lot of pathologies other than the niche. And here are the symptoms they make: abnormal uterine bleeding, like intermenstrual bleeding, postmenstrual spotting, pain, chronic pelvic pain, dysmenorrhea, dyspareunia, vaginal discharge, chronic infection, secondary subfertility. This is called Caesarean scar syndrome. Not only this, we also have something called niche call or niche quality of life. This is how the niche affect the psychological, environmental, physical, and social domains of the patient. It measures a lot of things in the patient's health and lifestyle. And the known thing we know is that the post-hysteroscopic repair of the niche quality of life gets improved. If you will talk about the infertility issue related with the cesarean scar complex, it is due to many things, not only the inflammation. It's due to the accumulation of mucus and old blood in the niche. This makes like impairment of sperm penetration, altered immunobiology due to the chronic inflammation, distorted contractility, malcontractility of the uterus, accumulation of intrauterine fluid, and chronic endometritis. In combination with the retroflexed uterus, which is a risk factor also for the cesarean scar niche, it can cause an impaired accessibility for embryo transfer. Also, the symptoms may interfere with the sexual life of the patient. Hello? Yes. How to diagnose? This is away from the scope of this lecture, but for me, we have to have a patient complaint plus imaging. When you find it just by imaging without a complaint, this is not a pathology. This is not something I'm looking for. So you can transvaginal ultrasound, saline infusion, sonohysterography, MRI, hysterosalpingogram can diagnose it in some views, and hysteroscopy. How to diagnose? Because this lecture, it is about hysteroscope. How to diagnose it by hysteroscope? This is it. This is the theory of how I diagnose it. I'm looking for a shelf. If you come to a shelf and you look from down, there is a hidden area on the upper surface of the shelf. This is it. Now, when you look here, this is the yellow is the light. When you see the view, you will see that we have hidden area in the scar that we can't see it by the hysteroscope. This is it. You see, this is it. There is a hidden area. This is the niche. Okay, but the defect, there is always a defect. So, what do we do for patients who have this pathology, cesarean scar complex? The first question is if the patient seeking conception or not. The second question is she has symptoms or not. If no symptoms, but she's seeking conception, then we have only one problem, which is the residual myometrium. So if the residual myometrium is above 3 millimeter, we don't do anything. Okay. If the patient has complaint, if the patient has a complaint and she is not seeking conception, then hysteroscopy is good. If the patient has complaint and she's seeking conception, I have to measure the residual myometrium. If it is more than 3 millimeter, then hysteroscopy is okay. If it's less than 3 millimeter, I have to go for suturing. So most of the patients will make use of hysteroscopy, except those who have a residual myometrium less than 3 millimeter and they want to get pregnant. So what's the hysteroscopic repair? It's a resectoscopy. It's not a hysteroscopic intervention. It's a resectoscopy, and the resectoscope is a different device than the hysteroscope, and it came from the urogynecologists, uroendoscopists, not from the gynecologist. So it is called hysteroscopy, but it is a resectoscopy. It's an electricity-based, electrosurgery-based. We make the resection of the niche throughout this dotted line. It's defect remodeling. Now we have to ensure about the terms. We don't remove the defect. We remove the niche. The defect stays. we changed the shape of the defect from a fluid retaining defect into a fluid non-retaining defect. It's defect remodeling. In literature, this is called symptomatic treatment. The hysteroscopic repair is symptomatic treatment. I think, no, this is definitive treatment because we are removing the whole pathology, the pathology itself, which is the niche. We don't remove the defect, but the defect is not the pathology. No scar augmentation till a very near time. This was true that when you remove a niche from a 3 millimeter Caesarean scar thickness, you don't weaken the scar and you don't augment the scar. But we'll see some recent publications showing differently. What's the technique? We remove the niche using resection and we coagulate the vessels and inflamed infected mucosa using a coagulation pole. We'll see now the details, but this is the idea. You remove the niche and you remove the shelf, and now everything falls down. There is no niche. This is the difference. Now when you go on the right side, when you see the hysteroscope now, you can see all the walls of the scar, and unlike the one on the left, there is hidden areas. So you remove everything until you don't see hidden areas. This is how it is, the surgery. We'll talk about the tools used for the surgery. Next topic. Now you see this is the defect. This is the shy bubble sign. You see half of the bubbles. You don't see full bubbles. That means something is hidden inside the defect. Now this is the niche. I will be removing the niche itself until I uncover all the defect. This is the technique. You go from inside the defect and it comes to you. Now see how inflamed is the tissue. All of this white mucus filled glands. You see how every time I remove a niche, I see this view. Mucus everywhere, inflammation everywhere, signs of infection, collections of bloody material inside the niche, inside the defect. You see inflamed mucosa inside. Until you have this, and now we don't remove. This is not removing. Now this is coagulation. I coagulate the wall, coagulate the inflammation, coagulate the vessels. You see up this inflamed mucus. Now the defect started to appear. The defect started to appear good. You see this is the internal os. In front of you is the internal os. We are in the isthmus. We are in the last area of the cervical canal, not inside the cavity. You see behind, in front of you, you see the internal cervical internal os. Now you see how we, after I remove, we don't have hidden areas. Okay. We have to do this up, right, left, and down. If you see the pathology, you see here downward we have the same view because it's inflammation. It's inflamed and it progressed to the posterior wall, and so this is called 360-degree operation. You operate in all directions. You see this? Okay. Ideally, we use the ball electrode, not this electrode, for the coagulation. I'll show you the picture, but I don't like to change the electrodes during I work. So I use the same one for coagulation and resection. You see this white balls? This is mucus from the endometrial, from the glands. The glands were full of inflamed and full of mucus. So when you open them, you just find the balls of mucus. I'm not going beyond the scar. I'm just removing everything between me and the scar. But we didn't touch the scar in this operation. We are not removing any big amount of tissue. The diameter of this loop, the diameter of this circle is 3 millimeters. Okay, so we are just, this is microsurgery. You see this inflammation, you have to remove and coagulate the wall. Okay, maybe we'll have to finish this here. You see, yes, yes. Hope you like this. It takes maximum 6-7 minutes. You see, now we started to have healthy tissue. This is coagulation. This is coagulation. Now coagulation, not cutting, not resection. Okay. This is how, this is the detailed pictures. Now, the first 3 pictures is what you saw. The last one is the ball electrode. This is best for coagulation, but I told you I just used the same one for resection and coagulation. Yes. Till everything I said was okay till last August, we had this paper, post-operative morphological changes of the isthmocele in patients treated by channel-like 360 hysteroscopic technique. They found that hysteroscopic resection for the treatment of patients with symptomatic Caesarean scar defect may lead to an increase in the residual myometrium thickening, decrease in the Caesarean scar defect, and improvement of symptoms after the procedure with high patient satisfaction. This is all known except that it may lead to an increase of residual myometrium thickening. That means that after the operation, you give a new chance for the scar to reheal again, and you start increasing the residual myometrium thickening. After I saw this, I start calling a lot of my patients who had low residual myometrium thickening, 3 milli and 4 milli, and I found up to doubling of the residual myometrium in these patients. So this is a very new news, and now we can say this resection surgery leading to reconstructive outcome. Okay, what is the tool we are using? What's the resectoscope we use? Because we have at least 5 common sizes of the resectoscope, and by sizes we mean the caliber, the diameter of the resectoscope. We have 26 French, which is around 9 millimeter, up down to 15 French with about 5 millimeter. 3 of them are called mini resectoscope. What is mini resectoscope? Mini resectoscope is a resectoscope that can be used without the need for cervical dilatation. 6, 5.5, and 5 millimeter, they can be used without the need for cervical dilatation of the patient. Okay, we use bipolar current. This is safer. This is always safer in all surgeries whenever available, but monopolar current is safe too. If you use monopolar, we use the cutting current only. We never use the coagulation current. In the coagulation of the walls of the scar, we use the cutting current also, not the coagulation. We don't use coagulation current. Cutting current for coagulation. Okay, why we use the mini resectoscope? Why it is better? Because cervical anatomical distortion may alter or mask a low-lying niche. I'm going to repair the niche with my view. It is how I see it needs repairing. It is it's not like a septum I have to remove and I know what I'm going to remove. In the niche, I remove until I uncover all the defect. So if I have cervical dilatation, if I did cervical dilatation, I will mask a niche. Sometimes you make cervical dilatation, you don't see the niche because you already opened the niche. You just go inside the defect. So the best thing is the natural anatomy of the cervix. You go inside and you operate. It's a mini surgery of remodeling, not gross resection. It's not a big myoma that I need to be removing large amount of tissue in a fast time. Many resectoscope, they're easier and faster, and they have less potential complications. Theoretically, the procedure can be done in the office because we don't need cervical dilatation, but we don't have any recommendations for this. My take-home message: cesarean scar niche is a compound pathology, may represent with a variety of symptoms. Hysteroscopy is not the golden standard of diagnosis, but intraoperative diagnosis is not uncommon. Suturing is still the standard treatment, whether transabdominal, transvaginal. Hysteroscopic intervention is excellent in correctly selected patients, and it's gaining more popularity. Bipolar mini resectoscope is the tool of choice. We have always to understand the pathology, assess the patient, and know all the treatment options to provide the best outcomes. Thank you. Thank you, everyone.
Thank you. Thank you so much, Dr. Munir. A very nice presentation. Nishant, will you take if any questions we have received?
Not yet, ma'am. We did not receive any question. One feedback we received from Dr. Yukti Bharadwaj. She told excellent talks.
Okay. One more we have received from Dr. Munir. Yeah. So thank you. Thank you once again, Dr. Munir, for your excellent talk.
Thank you.
Yeah. Program has gone live on the YouTube. I will share the link with you also. So with this, we will wind off today. As today, we have not received any questions today. So
no,
friends,
Ritu, can I ask? This is Dr. Anita Rajoria from Delhi. I just want to ask him after how much time he allows pregnancy to the patient after repair of the niche, if the patient is desirous of future pregnancy.
Dr. Munir?
Yes. Before I allowed pregnancy from the next month, just after the treatment of the endometritis. Now I think I give the patient 2 or 3 months for myself to follow the new look of the cesarean scar, because I'm working in this. But I think there isn't any problem if the patient gets pregnant soon.
Are there any guidelines to do some tests before allowing the patient pregnancy to be on the safer side? Have you encountered any rupture or scar rupture after repair of scar? I need to ask that.
We don't have any guidelines for this. There are many people trying to make studies about the residual myometrium thickening per se, postnatal or prenatal, but I think that there isn't any risk for uterine rupture. It is wound dehiscence. We have a lot of patients who have very low residual myometrium and they just get pregnant. They don't have any, they get pregnant and they come you see them at 30, 37, 38 weeks during the cesarean section. You see the uterus opened and there is only peritoneum. I think this is common and it's safe. It is far from the idea of rupture uterus and antepartum hemorrhage and this scenario. It is just it is very fibrosed hole in the uterus. That's what I think. This is not my area of work.
What is the choice of suture material, Dr. Munir? What is your choice of suture material?
I work hysteroscopy only most of the time. So I'm not even in the etiology of the disease. I don't have specific things, but I think
I mean, the niche repair, if you're doing scar niche repair laparoscopically or open for that matter, what will be your suture material of choice?
Yes. I the only thing I would do it with the laparoscope is in the presence of an endostitch. Suturing by hand is very weak to hold up such a scar.
Okay. Thank you so much.
Thank you.
Yes, sir. We also received one more question from Dr. Archana Khurana. What is the treatment choice for post cesarean section continuous spotting with USG showing niche?
Well, if the patient wants to get pregnant, the niche has to be repaired, and I prefer hysteroscopy if the residual myometrium is good. If the patient doesn't want to get pregnant now, you can use any hormonal or Mirena that decreases the menstrual blood or causes endometrial inhibition.
Thank you so much, sir. I hope Dr. Archana received her answer. And we also received one more feedback, Dr. Renu Bhatia Raval. Sir, it was an excellent talk.
Thank you.
So, Nishant?
Yes, ma'am.
Nishant, please mind off. My throat is very bad. I'm not able to speak even. Huh?
Hope you are well soon, doctor.
Yeah, yeah. Thank you so much.
Take care.
Thank you so much.
Bye.
There are no more questions, so we can wind up for today's webinar. Thank you all for joining today's session, and I also thank Dr. Munir Mustafa to give him his precious time for us, and Dr. Ritu Santwani ma'am for making this webinar possible on Shield Connect. Thank you so much, sir. Thank you, ma'am.
Thank you. Thank you, everyone.
Thank you so much. Thank you.
Thank you.